everyone to one of two webinars from the National Hospital Queen Square, really reflecting on the last 10 years of stereotactic radiosurgery in our hospital, and where have we come from, and where are we now. And I'm joined today by three experts in the field from our unit: Ian Paddick, consultant physicist; Patrick Grover, consultant neurosurgeon; and Dr. Michael Cosman, consultant clinical oncologist. So we have three talks, and then at the end of those talks, we're going to have a Q&A session, but we have to finish by 7 p.m. We only have 1 hour. So we'll try not to overrun, and we will be looking at your questions as we go through the talks and selecting what we feel are the important ones. So please type in the chat box as the speakers talk, and we'll come to you at the end of the talks. So without further ado, I'd like to ask Ian to take the stage and to give his talk, please. Thank you, Ian.
Well, thank you very much, Neil. It's been a pleasure to serve as the chief physicist at Queen Square for the last 10 years. And during that time, we've been asking, how can we make SRS treatments better? I was already on the road to asking that question before I joined Queen Square. And I think, first of all, we need to agree what the hallmarks of radiosurgery are. I would argue that they are conformity, that's shaping the radiation dose to the target, so you're treating just the target and not the normal tissues. You want to have a steep dose gradient, so that's ensuring that dose falls to a low level outside of the target. But you also need to have accuracy, ensuring that you have confidence that the dose is being delivered where you want it to, and also the amount of dose as well. So as a background, I proposed the new conformity index, now called the Paddick Conformity Index, 22 years ago, before I knew about the possibility of having a gamma knife at Queen Square. But that sort of gives you some of my background. And I also published the gradient index, which is about measuring the dose fall off outside the target. Before the gradient index, there was no real universal way of being able to measure that. But during the time at Queen Square, we've continued to ask, how can we better describe the quality of the treatment? And so this is one study that we published with my colleague Alexis Dimitriadis 4 years ago, where we looked at the efficiency index. Well, this is what we called it. And classically, efficiency is about the useful energy divided by the total energy. So we asked ourselves the question, well, maybe we could use that to describe radiosurgery treatments, where the useful energy is the energy inside the target, and the total energy includes a proportion of the tissues outside of the target. It seems to be quite intuitive to do that. And here are two treatment plans. On the left, we've got a gamma knife treatment plan. On the right, we've got a LINAC treatment plan. And while the dose conformity is actually ever so slightly higher with the LINAC treatment plan, when we look at all of these values together and work out the efficiency index, it turns out that the efficiency index of the gamma knife treatment plan is 50.1%, while on the right it's 43%. And that's because you're packing in more energy, more dose into the center of the target when you treat with the gamma knife. Now, whether that has clinical implications, that's something that we look forward to finding out in the future, but at least we're able to measure it. So the other question we can ask is, can we use indices to determine which SRS platforms are better? And I've enjoyed the work I've done in this area, starting with the benchmarking, NHS England benchmarking in 2016, where I had the pleasure to work with David Eaton and the RTT QA team, where we asked those kind of questions. And then I was invited to the Irish Radiosurgery Symposium in the summer of 2019, I was representing Queen Square Gamma Knife, and we pitted ourselves against CyberKnife, a Linac with cones, and also the variant HyperArc, which had just been installed at the Beats in Glasgow. And we published this study where we looked at, we planned 5 multiple metastasis cases to the best of our ability. And you can see in the 2 tables here, which nicely summarize the study, you can see that the conformity index in the top table, we came neck and neck best in terms of conformity with the HyperArc with a value of 1.12. That's the RTOG conformity index. But then if we look at the gradient index, you can see that the Gamma Knife did significantly better than the HyperArc Linac there. And so if you combine those 2 together and look at, let's say, the 12 gray volume, which we know is a predictor for symptomatic radiation necrosis, you can see in the top left table, if you look at the total V12, it's significantly lower. There's a lower volume with the Gamma Knife. And now we're working on another study. Why is another study needed? Well, equipment's been refined. Treatment planning systems have improved significantly over the 6 years since the NHS RTTQA benchmarking tests. And new equipment has been launched as well. So we've got devices like the ZapX now. So we asked ourselves the question, have technological improvements led to a corresponding improvement in treatment plans? And these are the platforms that we looked at. So we have the Gamma Knife Icon. We have the CyberKnife, which is represented by the Royal Marsden Hospital. We have an Electa Agility. We have a Varian TrueBeam. We have a Varian Edge with HyperArc. And then we have a ZapX. So all of these devices were trying to plan cases to the best of their ability. And we used the 6 original RTTQA benchmarking tests from 2016. And then maybe to represent the evolution of SRS, we included a 7th case, which was a patient with 14 small metastases. And that, while in 2016 that was considered to be outside of the normal range of SRS, I think now treating a patient with 14 small metastases is relatively commonplace. So we agreed prescription doses for each target. Linacs added a 1 millimeter margin, and because they added a margin, they reduced their prescription doses a little bit for metastases. We agreed tolerance doses for the organs at risk, and we tried to get 99 to 100% coverage for metastatic targets, but we reduced that down to 95% acceptance for benign targets. And then we looked at a wide range of parameters: coverage, selectivity, Paddick conformity index, gradient index, something we call the R50%, the efficiency index that I've already mentioned, doses to organs at risk, and then estimated planning and treatment time. So if we look at the conformity index, this is quite interesting. In 2016, the Gamma Knife came out pretty much top or neck and neck with the CyberKnife, while here you can see the blue circles represent the Gamma Knife. And in this case, the Gamma Knife sort of wasn't the highest, wasn't the lowest in terms of overall conformity, which actually surprised me quite a bit when we saw these results. If we look at the gradient index, so that's the steepness of the dose fall off outside the target, you can see that the Gamma Knife still appears to have the steepest gradient on average. Very closely behind was the ZapX. And then if you combine conformity and gradient together to use the value called the R50%, you can see that the combination of the two yields where a low value is considered to be best for radiosurgery. then you can see that Gamma Knife comes out very well indeed, with generally the lowest R50% values for the different targets that we were planning. Closely behind that is CyberKnife, ZapX, and then the stereotactic Linacs. Then if we look at planning and treatment times, we know that the modern Linacs can treat patients very, very fast. But the planning times we see here tend to be longer. So the orange represents the planning time, while the blue represents the treatment time. So Gamma Knife, CyberKnife, and ZapX tend to have relatively long treatment times, but you can see that actually the shortest planning times came with the Gamma Knife in this series of cases. So to summarize, and we've already delivered an abstract and a presentation at the ISRS meeting, but we're yet to publish this data. Planning indices are generally improved, particularly for the C-arm Linacs. Cobalt and 3MV, which is the energy used by ZapX, still appear to yield a superior gradient for small targets compared with the conventional Linac energies, that's 6 and 10 MV. And planning and treatment times vary dramatically between the different technologies. We can also ask ourselves the question, can automated computer planning produce better plans? Which is better, the computer or the physicist? We've been very lucky to have Lightning. Lightning is an inverse planning system using a linear method of producing the optimal plans. And we were able to investigate that at Queen Square, as we were one of the first centres to get that in the world. And you can see a case like this where it's a large cerebellum met. It's really quite complex in shape. We want to be as conformal as possible. And Lightning can produce an incredible plan. This is the plan. It's 101 isocenters. And if we look at that in terms of beams, we're talking about almost 20,000 beams just treating this individual target. But is it better than a manual planner? Well, one thing that you have to do when you're using Lightning is you have to vary the different parameters. You've got a parameter of low dose and a parameter of beam on time. And by varying those, you can get different results. And we can see these in what we call these heat map tables that were produced by my colleague, Anna Karanatsiou at Queen Square. And what we can do is we can look at different points on these charts. So if we use a relatively low dose weighting and low beam on time weighting, we get on the left, these are conformity indices. On the right, this is beam on time in minutes. So we achieve a good conformity index, 0.91, but the beam on time is 155 minutes, which is clearly quite inefficient. But if we use different beam on and low dose weighting, we can get the same conformity index, 0.91, but we can achieve that with a treatment time of just 62.5 minutes, which is much more efficient, better for the patient. So there are some tips and tricks involved in optimizing these plans. So for instance, manual intervention allows us to manually refine the plan a little bit, just to make it a little bit more conformal. So even though the computer does a very good job, manual planning can achieve often a better plan than if you just use a computer to do it yourself. We can also use tuning structures to optimize the treatment plan. That's something that you need to really guide the computer along its way to optimize the treatment. So Lightning was perhaps Elekta's response to an inverse planning system by a company called Intuitive Therapeutics. They were the first to produce a solution that used linear programming. And we were one of the first to evaluate that software at Queen Square. This produced better plans, but longer treatment times. And then we used the same cohort of patients and repeated the study using Elekta's Lightning solution. And we've presented that at the ISRS meeting, and we've had our abstract published. So here you can see the manual, the intuitive plan, and the Lightning plans. And generally, Lightning appears to be more efficient than intuitive plan in that you get an equally good treatment plan, but with a lower beam on time. Although you can see if you plan manually, although the conformity isn't quite as good, the beam on time is significantly less. And you can see the number of isocenters there is about a quarter of that using the linear programming method. So our practice at Queen Square is we've analysed we've treated over 500 patients now with Lightning and evaluated almost 500. We found that the proportion of plans using Lightning is just over half, at 50.6%. But there's a very, very small number of Lightning plans, just 2.5%, that were produced with a single click. So all of the others required some manual intervention. So while Lightning is certainly, I think, superior to an expert dose planner, the combination of the two together produces an even better plan. And we can see here in this chart which targets benefit from using Lightning most. So you can see generally the larger the target, it tends to be the more likely we are to use Lightning to plan it. Radiobiology is also very important, and we're lucky enough to have a link with the Oxford radiobiologists that I work with pretty much on a daily basis at the moment on a number of studies that we're looking at. So we know that sublethal repair during a prolonged treatment, that's any radiation treatment that lasts for more than 10 minutes, reduces the overall biological effective dose of the treatment. And in this study, we were able to show it very clearly with, this is clonogenic cell survival studies. If we look at the chart on the right, and we look at the dose required, if it's delivered instantaneously, to produce a surviving fraction of 0.001%, it requires a 26 gray dose. But if that treatment is delivered over a period of 2 hours, to get exactly the same cell kill, you need to deliver 35 gray. So that's a 35% difference in the dose to get exactly the same biological effect. And we've felt that this was also the case for clinical treatments, but it wasn't until about 5 years ago that we've been able to demonstrate that. And so I was lucky enough to work with the group from Marseille and look at the very first clinical study comparing dose versus biological effective dose for clinical outcome. So we looked at almost 500 patients treated with trigeminal neuralgia. They were a relatively simple cohort to look at. And what we found was that as biological effective dose increases, you get very little difference in the overall pain control. But what we did find was that in our lowest biological effective dose group, we had an incidence of 5% of hypoesthesia, while in the highest group, we had an incidence of over 40%. So what we're basically seeing here are the two classic sigmoid curves that you get in radiation oncology, where one is tumor control, in this case it's pain control for trigeminal neuralgia, and then another sigmoid curve which represents complications, in this case hypoesthesia. So this is classically what we would expect, and it's what we saw in that cohort. And Queen Square was one of the very first centres in the world to use this study to prescribe ISO-BED treatments. So in this paper, we published a table where you can look up the inpatient dose rate and you can adjust the prescription dose in order to achieve an ISO-BED treatment. And therefore, we should have much more consistent treatments and a lower rate of hypoesthesia. We've also been interested in not just protecting the normal brain, but protecting the whole patient's body as well. And in this paper, we looked at the body dose received by 20 patients receiving radiosurgery. And we looked at those doses and compared those with other platforms in the literature. And this is the chart that we obtained. And to our surprise, we found that there's about a factor of 10 between the dose received by the patient using a gamma knife versus that of a Linac, and almost 100 between a gamma knife and a cyber knife. Now, for a lot of patients, that's not going to make any difference, but if you're very young, it does make a difference. And what we found in this chart at top left, these are the lifetime equivalent risks for patients treated with a gamma knife. For all patients, even the highest risk patient, which is a 5-year-old female being treated to 25 Gray, the risk was less than 1%, while for other platforms, that's significantly higher, can exceed 10%. So we said these lifetime risks vary dramatically depending on the age and the sex of the patient, the radiosurgery platform used, and that should be considered when offering treatment. We've also looked at treatment accuracy, which I mentioned was the third hallmark of radiosurgery. And in this study, looking at frame stability, we found that there was very little evidence for frame movement or inaccuracy using the frame, with a comparison between the MRI and CT scans of just 0.71 millimeters. And then recently we've looked at Vantage frame accuracy, and in this study we found an accuracy of 0.55 millimeters on average using the Vantage frame, which allows us to use higher Tesla magnetic field strength for imaging patients. So we're improving our imaging as well as our accuracy. So the ongoing research we have is looking at biological effective doses for vestibular schwannomas. We've submitted that this morning, actually. Looking at BED versus thalamotomy treatment. We've got further benchmarking studies. We've got the ISRS technical guidelines, which was led by the physics group at Queen Square. That's in press now. And we're also looking at body doses and associated risks in the treatment of pediatric AVMs, because that's something that we do a lot of here at Queen Square. So hopefully I've shown you very quickly that at Queen Square we've been dedicated to investigating how we can improve treatments and increase their consistency. The benchmarking studies consistently demonstrate that gamma knife delivers treatments with the steepest dose gradient, and that protects the patient's healthy tissues. And indices and biological effective dose are helping us to quantify and improve treatment quality. So thank you very much for your attention.
Thanks very much, Ian, for that a tour through the last several years of physics and gamma knife and what we're doing at Queen Square. So thank you so much. I'm delighted to note that we have over 100 attendees to this webinar. So please type in your questions. We want to hear your questions, and you'll have your chance to ask our experts those at the end. Now, our gamma knife is run by both neurosurgeons and clinical radiation oncologists together as a joint team, and Michael Cosman is one of our senior oncologists on that team, and I will hand over to him for his talk. Thank you, Michael.
Thanks, Neil. I'm going to just spend the next few minutes taking you through a couple of interesting areas that we've been developing in the management of metastatic disease. So initially, I'm going to talk us through some background. So as an introduction, I know the audience here will know some of this, but up to 40% of all cancer patients now will develop brain metastases at some point through their cancer journey. And this is thought to estimate to about 20 to 25,000 new patients with brain metastases per year in the UK. And further estimates are that approximately 10% of these, or about 2,000 patients per year, are likely to be suitable for stereotactic radiosurgery, both in terms of the technical nature of their disease, but also their clinical presentation. And we also understand that over time there has been a change in how brain metastases have presented, and we've seen a reduction in patients with single metastatic deposits and an increase in patients who are presenting with multiple metastatic deposits. And there are some statistics on the screen there illustrating that. And what we also know is that patients who are not suitable for treatment or who decline treatment for their brain metastases have a very poor outcome. One of the challenging areas when it comes to managing brain metastases with gamma knife is patients with large brain metastatic deposits. And we know that these larger lesions have inferior local control rates. And we know that giving high doses of radiation to larger lesions is associated with high rates of radiation necrosis. And so there are some approaches that have been tested to try and improve the outcomes for these particularly difficult to treat patients. And one approach that we use at Queen Square is the delivery of what's called staged gamma knife treatment. And so rather than giving a single fraction of SRS, these patients will undergo 3 separate treatment fractions with a 2-week interval between each treatment. And so we tend to consider this treatment for patients who have large metastases, as I say, but it can also be considered for lesions that perhaps aren't particularly large in and of themselves, but they're in either a very eloquent location or they are associated with significant edema. And we are concerned about the clinical reaction that we might see to a single fraction of treatment. And what we see with our staged gamma knife treatments is we often find that there's been a significant response in the intervals between the first and second, and then second and third fractions of treatment. And that enables us to adapt our target volumes down and reduce the dose to the normal tissues around our target, of course, thereby reducing toxicity. And this is just one case example here, which is a case of a breast cancer patient who started off prior to her first fraction of treatment with the scan on the left, which shows a target volume of approximately 10 cc's, which was treated to a single 10 gray fraction. And then 2 weeks later, the patient comes back for the second treatment, which you see as the second image. And then finally, the third fraction of treatment 2 weeks later still, with a reduction by that point of 63% in the size, in the volume of the target lesion in comparison with where the patient had started 4 weeks previously. And the follow-up imaging 6 weeks later showed a continued response to treatment. So this just illustrates, I think, the benefits that we get with offering staged treatment to patients with larger metastases. We get good control, but we're also able to adapt and reduce our target volumes at each of the treatment sessions. And as I mentioned before, we consider staged gamma knife for large metastases, but we also consider it for metastases in awkward locations. And you can see here a cystic metastasis in the pons. And again, we can see the imaging at fraction 1, fraction 2, and fraction 3 here on the screen. We don't see a significant response during the 3 stages of this treatment. The images are kind of similar, aren't they? But come the post gamma knife treatment response assessment scan at the bottom right, we start to see some involution of the cystic metastases. But I'm also interested in having a think about what's happening in the time intervals between these treatments. So what is happening biologically within these lesions, and what is explaining the changes in volume that we see? And following on from that, is there a better way to distribute the dose at the second and third stages of treatment based on the changes that we've seen within the lesion? And so we have a study open at Queen Square, which is looking at using multi-parametric imaging for us to get a better understanding of how these brain metastases are responding to the stages of treatment that they are receiving. And so we're looking at perfusion through these metastatic deposits and the cellularity using diffusion imaging, as well as some more complex imaging looking at the tumor microenvironment. Okay, the second topic I just wanted to cover briefly was a retrospective study we did looking at our elderly patients. And so we have a cohort of patients that we've looked into who are aged over 80 years and have been treated with gamma knife for brain metastases. And we went back and looked at those patients treated in a 4-year interval between the summer of 2017 and the summer of 2021. And we identified 24 patients who we treated who fall into this group. There's a slight male preponderance, but the age of treatment did range from 80 all the way up essentially to 90 years old. There's a range of primary tumors, although the majority had melanoma and had been referred in by their melanoma oncologists. And interestingly, approximately half of patients had their metastatic disease identified at routine imaging because essentially they were asymptomatic, and the other half did present with neurological symptoms. The treatment characteristics of this group, so we treated it between 1 and 15 separate targets in these patients, and the volume treated at each of these treatments ranged from a very low volume of 0.03 cc's all the way up to 15 cc's. You can see the median values in brackets here. And the treatment doses were as you would expect for patients of any age. And what we found in this particular group was that 92% of patients had maintained local disease control. 8% of them therefore hadn't. Another 8% had new intracranial sites of disease after treatment at some point. 46% of these patients had progressed extracranially, and 38% of patients had no evidence of intra or extracranial progression. The overall survival for these patients, the median overall survival was 10 months in this group of 80-plus-year-old patients treated for metastatic brain disease. So in conclusion, looking at this cohort, we felt that this showed that gamma knife is an effective treatment modality for patients who are over 80 years of age with brain metastases, as long as they meet our other clinical and technical criteria. And given the relatively good outcomes in this group, age should certainly not be a barrier to gamma knife when these other clinical criteria are met. Thank you very much. I'll hand you back to Mr. Kitchen.
Thanks so much indeed, Michael, for that talk. So we have a number of subspecialties involved in treating on the gamma knife in Queen Square. And our next speaker is Patrick Grover, who's one of our consultant neurosurgeons who deals principally with skull-based tumours, but also vascular neurosurgery. So Patrick, over to you.
Hi, everybody. So I'm going to go through some cases and just discuss a little bit about cavernomas and their management. Cavernoma, so for those of you that may not be so familiar, is a vascular malformation of the brain. These are usually small abnormalities and in fact are diagnosed incidentally in a large number of patients and do not cause any symptoms at all. But a small proportion of them can bleed, and if they do bleed, particularly in significant locations, they require treatment. And the treatment options really are either surgical excision or stereotactic radiosurgery. So this first case is a 39-year-old lady, and she really illustrates our sort of general management of these patients. She had 3 bleeds from this cavernoma in her pons over a course of about 2 years. The first bleed, she developed double vision, some pins and needles, and some weakness on the right side, and she recovered fully. And then about 18 months later, she had 2 further bleeds. At that stage, she then developed double vision, again the weakness and numbness, and after that, she was left with some residual weakness in the right hand and also the foot. and also persistent sixth nerve palsy. She had seen some local physicians and surgeons, and they counselled her that it was too dangerous to treat, so she was managed conservatively, and then she came to visit us for a further opinion. So I hope you can see my arrow, but you can see there that after the first bleed, the evidence of the cavernoma in the pons, and after the second and third bleeds, this is clearly more prominent, just in the region of the facial colliculus. She did not have any facial weakness. So we treated her, and this is the kind of treatment plan that we would do for cavernoma. So it's a very small lesion, so a very small plan. She had 13 gray to a 60% isodose. The treatment volume is 0.041 cc's, and the max dose is 22 gray. I've followed her up now for approximately 2 years or so. She had one further clinical episode of some new pins and needles in her foot at 18 months. We imaged her, and radiologically there was no change, and indeed that episode of paresthesia resolved as well. So she's had no further bleeds after treatment. So in terms of treating cavernomas, why do we treat them, and how do we go about the decision making and deciding on which ones to treat and which ones not to treat? So the evidence that is often quoted is from a meta-analysis in 2016 demonstrating the risk of hemorrhage at 5 years in cavernomas which have previously bled, and the 5-year risk is approximately 30% if you have a brainstem cavernoma of having a further bleed, and it's approximately 18% if you have a non-brainstem cavernoma, so a supratentorial cavernoma. So these are the kind of figures that we use then to weigh against the risks of the intervention, whether that's either surgical excision or gamma knife or different forms of stereotactic radiosurgery. So we performed a systematic review of meta-analysis, and we looked at the literature and took 70 cohorts which satisfied the criteria for our meta-analysis. This included 5,000 patients, and this was patients having surgery for cavernomas. And the composite outcome was either death, intracerebral hemorrhage, or a persistent neurological deficit after intervention. And over 100 patient years, the rate of that outcome was approximately 4%. As you'd expect, it's slightly higher in a brainstem location, so closer to 6%, and lower in a non-brainstem location in the region of 2%. And we set that against radiosurgery. So this is also with Rustam Al-Shahi's group in Edinburgh, so using the same methodology, and this is a meta-analysis looking at the outcomes after radiosurgery. This is 30 cohorts, just over 1,500 patients, and you can see here in the bottom right, the same composite outcome, and the rates of, again, death, ICH or focal neurological deficit, around 4%. So really equivalent in terms of the safety profile. And the question really for SRS is it effective? So are we actually reducing the risk of bleeding or not? So if you remove a cavernoma surgically and you demonstrate it's gone with post-operative imaging, then it will not bleed again. But with SRS, you're much more uncertain because you're stabilizing the lesion, and then you're looking at the stochastic rates of bleeding. So the evidence, this is looking at particularly brainstem cavernomas. This is pooling 14 studies, and there's a clear reduction in hemorrhage rates between 0 to 2 years after treatment and more than 2 years after treatment. That's very significant. Cavernomas are reduced in size in about 47% and stable in 49%. The rates of symptomatic radiation edema are approximately 7%, of which 2% are permanent. And that's quite dose dependent. So if you treat with less than 13 gray, your rates of radiation edema are less than 2%. And if you're treating with greater than or equal to 13 gray, then it's towards 10%. And also 10 out of the 14 studies showed that symptoms are either stable or improved after SRS. So question really, although we can demonstrate this by looking at the literature, this evidence really is looking at multiple case series. And the issue with cavernomas really is that the bleeding from a cavernoma often happens or occurs in clusters. So you could posit that actually you treated the cavernoma after the cluster of bleeds has happened, and it was actually never going to bleed again. So is this really a significant difference or not? This is our experience over the recent few years of patients who have sufficient follow-up. So 13 patients that we've treated, the majority in brainstem locations and about 25% in the basal ganglia. The median dose is 13 gray. As I say, the treatment volumes is usually very small, so 0.2 cc's. And on average, all the patients that we have treated have had at least 2 prior bleeds. The median time from the first bleed to the treatment is about 2.5 years. So that includes obviously referral, decision making, and then waiting times for treatment. In terms of outcome, the median follow-up for this cohort is 3.5 years. We've had 1 case of permanent symptomatic radiation edema. So this case has been followed up for approximately 8 or 9 years. There is some increased signal change in the brainstem surrounding the treatment area, and the patient does have some worsening balance as a result. So I think we could ascribe that to symptomatic permanent radiation edema. The other 12 have had no side effects. And we've also demonstrated no radiological bleeds after treatment. So of all those cases, with that follow-up of 3.5 years, we haven't had a single further bleed from any of these treated lesions. So to interrogate this in more detail, in collaboration with, particularly this has been set up by Rustam Al-Shahi in Edinburgh and Mr. Kitchen, we have set up the CARE trial. So the CARE trial stands for Cavernoma as a Randomized Effectiveness Trial, and this is a randomized control trial comparing patients who either have conservative management, stereotactic radiosurgery, or surgical excision of their cavernomas, and then interrogating and comparing whether or not there is a reduction in their bleed rates, for example, and if there is an acceptable rate of complications and side effects. So any patients of any age are included. The main inclusion criteria really is that you have to have a brain cavernoma diagnosed and at least 1 symptomatic episode ascribable to that cavernoma. That enables you to be enrolled into the trial. The patient and the doctor have to be uncertain. Has to be some degree of equipoise as to the best treatment. So is it better for the patient to have ongoing surveillance or the treatment? And they have to have capacity to consent. In practice, we discuss each case in our MDT meetings, both locally and in the Gamma Knife MDT at Queen Square. A consensus is agreed between the patient and the clinician and the MDT as to what is the best treatment. So is it actually feasible for surgery? Is it feasible for radiosurgery or not? Which is the better option? If there's no clear preference, then the trial can randomize to either surgery or radiosurgery or conservative management. This is typically done in local referring centres, and then the patient is referred to Queen Square to deliver the treatment. But we also obviously randomise patients in our catchment area also. This is a scheme published by Peter Whitfield, just giving us a sort of overview of how cavernoma decision-making should be considered really in the modern day. So a brainstem cavernoma, which is the majority that we're talking about, is confirmed on an MRI scan. If there's no bleed, then we will manage this with surveillance. If there's a single hemorrhage, then consideration should be given to stereotactic radiosurgery. If there are multiple hemorrhages and it's reaching a peel surface, so it's accessible and can be safely removed surgically, then microsurgical resection is or should be considered. So clearly there's debate about how different approaches are taken, and in some centres surgery will be used more highly, for example, or conservative management in other units. But this just gives an overview really. And I think that with the CARE trial, of particular interest are the group that have had a single bleed, because typically in a lot of cases in a slightly eloquent location or deep in the brainstem, historically, all of these patients will have been treated conservatively. And I think one of the main questions the CARE trial is asking is, actually, would we be benefiting these patients by intervening sooner? So should we be treating them sooner and preventing that second or third bleed, and therefore preventing progression to permanent neurological deficits? So of the patients that we've treated at Queen Square, as I say, the time from first bleed to treatment was about 2.5 years, and approximately 75% of the patients had a focal deficit by the time of treatment, and the majority of those had progressed between the first and second bleeds. So could those second bleeds or third bleeds have been prevented by earlier treatment? So just the last couple of slides, these are the first cases that we've now randomized to the CARE trial. So this is a 49-year-old lady. She's had one bleed from a pontine cavernoma. She has some right-sided weakness, numbness, and double vision, and we have randomized her to radiosurgery. She was in the radiosurgery versus conservative management arm. And the second case, which has been treated, 42-year-old lady, referred from a local centre with multiple previous bleeds from pontine cavernoma, and has had this treatment a few weeks ago. So the take-home messages are that stereotactic radiosurgery for cavernomas is safe and appears to be effective. The evidence in the literature is really limited to case series and meta-analyses of these case series. Earlier treatment may be beneficial to prevent progression to permanent neurological deficits, and really the CARE trial should help us to determine the nature of this benefit, hopefully over natural history.
Thanks so much, Patrick, indeed. Could I ask the other speakers to come on the stage? Okay, so we've got 10 minutes or so left, and we've got some questions which I'm going to sort of paraphrase for our panel, and but please keep typing in questions and we'll answer as many as we can. So without further ado, the first question was to do with when does the benefit of dose reduction to normal brain finish when treating multiple metastases with SRS? That is to say, if one's treating once and then twice and 3 times, when does actually, or if ever, does the dose to normal brain really supersede that which will be given by whole brain radiotherapy in the first place? Maybe I can ask that to Michael.
Sure, thanks, and thanks for the question. It's one we actually get asked a fair amount, and it kind of also boils down to, if a patient has had gamma knife treatment for metastatic disease previously, does that preclude whole brain radiotherapy at a later date, or preclude or need some alteration in the fractionation for whole brain radiotherapy later? And it's a good question, because actually what we found out when we've looked into this is that the equivalent whole brain dose is remarkably low with gamma knife radiosurgery. So just as an example, we had a patient who received 3 separate gamma knife treatments for a total of, it ended up being 58 metastatic lesions over these 3 treatment sessions. They were all very, very small in volume, but the overall whole brain equivalent dose delivered was of the order of 1 to 2 gray for each of the 3 sittings. So in terms of the question is, does it add up to whole brain dose? The answer is essentially no, it doesn't. Clearly, the larger the lesions are and the more normal brain is included in treatment, it can become more problematic. So what we would recommend is, if what we have treated a patient previously, and you as an oncologist or you as a clinician in another team wanted to know what the right thing to do was, we would want you to contact us back. We could then have a clinical discussion with you about the treatment that had been delivered previously and make some decisions about the appropriateness of more radiation and whether the standard whole brain radiotherapy dose fractionation should be altered in an individual case.
Great, thanks so much, Michael. The next question is, does dose gradient matter most for recurrent metastases treatments? Ian, do you have any comments about that?
Thanks, Neil. I don't think we have enough evidence at the moment, but common sense tells us that if a patient's been previously treated, their normal brain tissue close to the target is going to be closer to the tolerance dose for that tissue, and having a steeper dose gradient is going to help protect that. So although we don't have any direct clinical evidence, our understanding of radiobiology is such that we would expect it to be beneficial.
Okay, well, what about to sort of change it slightly, the dose gradient, should it be less steep for malignant disease than it should be for benign disease?
It's a very good point. In terms of what we know, we know that there's a direct correlation between the volume of the 12 gray and symptomatic radiation necrosis. So we know that if that's smaller, the patient is less likely to develop symptomatic radiation necrosis. And the steeper the dose gradient, the smaller the 12 gray volume. In fact, if you're treating to 24 gray, the 12 gray volume is your prescription isodose multiplied by the gradient index. It really is that simple. So we would expect it to benefit. For disease that's malignant but diffuse, well, that's a different issue. And maybe having a poorer dose gradient might help. We don't know. Yep. There's not a lot of evidence to demonstrate that margins improve local control. We know they increase complications, but the clinical studies that I've read suggest that they tend to just increase complications, even though they seem like common sense. If you've got a certain inaccuracy, you might want to add a margin.
Okay, thank you. Moving on, Michael, two questions for you grouped together. Is staged SRS as effective for all tumor histologies? And how large does a lesion need to be before considering stage treatment?
Okay, thanks, Neil, and thanks to whoever asked these questions. So staged SRS isn't, well, all SRS is not equally effective between histologies. There are certain primary cancers which are more sensitive to radiation treatment, and certain primary cancers that are more radiation resistant. One of the benefits of stereotactic radiosurgery is the high doses that are given, which can often offset some of that radiation resistance, at least partly. So the literature will say that there are certain cancer types that respond better, but I think we have good outcomes from all primary histologies, and we certainly wouldn't decline to treat a patient because they had a certain underlying primary cancer type as opposed to another. There would be other technical and clinical factors that would assist in that decision making. For example, I think the literature would point towards breast cancer patients having better outcomes than, for example, non-small cell lung cancer patients, but there will be a variety of other factors that will need to be considered, and there'll be significant overlap between the outcomes of those two patient groups. And the other question was regarding
size.
Yes, how large do we need to consider? How large does a lesion need to be before we consider stage treatment? As I alluded to in my talk, size will be one factor. The other factor will be the location itself and the amount of edema that is around the lesion. Although we think about these lesions as volumetric targets, we also within kind of MDT settings and clinical review settings think about the diameter of lesions as well as one factor. The two are obviously linked. So any lesion that is perhaps greater than 3 centimeters in diameter, we would be considering and having a discussion between ourselves as practitioners as to whether this would be a lesion that would be suitable for staged treatment. As you saw with the pontine metastases, that was a smaller lesion, but because of its location, we felt warranted staged treatment.
Thank you. The next question is, do we routinely use MR imaging when delineating target volumes? Yes, always. And if we do we use MR distortion correction algorithms? We do. But as his more general point is that, and Ian will agree with me, I know, that it's not a trivial task to when you have a hospital where there's multiple MRI scanners, to ensure the QA is right, so that we have stereotactic accuracy from the various MRI scanners, which might be made by different manufacturers, have different ages, different signal strengths, and so on. So a very important part of the physicist's occupation in Gamma Knife is to make sure the imaging is superb, which it is at our place. Now then, a general comment which I'm going to read out, and then a question. It is quite exciting to see what's progressed in the last 10 years. What are we looking forward towards in the next 10 years? And how easily can Gamma Knife be available for more NHS trusts? Certainly for centres who would like to take this route for brain SRS treatment. I think we've done certainly the NHS procurement exercise several years ago did spread the load of SRS treatments more evenly across the country, which I think was a good thing. And we now do collaborate with both other Gamma Knife and LINAC units, and I think there is better access for patients. And I think there has been a move towards focal treatment rather than whole brain radiotherapy amongst metastatic groups. But maybe any comments from my colleagues regarding access and what might happen to SRS in the next 10 years?
If I could make a point for the treatment of vascular lesions and functional targets, then Gamma Knife is available to every NHS trust just through a referral. For more complex cases, I understand that an out-of-area referral is possible. So we do receive some referrals from centres that find that their own equipment isn't up to the task for a particular lesion or number of lesions.
Yeah. Thank you. Is current Gamma Knife radiotherapy suitable for a meningioma that is hard to get to locations such as Meckel's Cave, and is it safe? Or yes, that is a very good site and a very good pathology, as long as the size isn't too great. And so yes, we routinely get referrals, as do other Gamma Knife units, for those pathologies. Next question: is there a maximum number of brain metastases that can be treated as long as the patient is stable on systemic treatment and asymptomatic for the brain mets? Michael, would you like to take that? Is there a maximum number of mets?
So there isn't, strictly speaking, a maximum number of metastases. The more metastases you try and treat, the more you're moving away from the evidence base, which is strongest for the smallest number of metastases, and equally strong up to about 10 metastases. And then above 10, there is evidence, but it's perhaps not quite as robust. In terms of the absolute number that we would treat, I think there needs to be a discussion with the underlying the patient's primary oncology team, because if there is such a widespread metastatic disease, it may be a case where focal treatment is perhaps not going to be beneficial for that particular patient, particularly if there's multiple new sites of metastatic disease that are developing relatively quickly. But these cases are certainly ones that we discuss in our MDT meetings. Thank you.
I mean, the numbers have gone up, certainly. I think there are two issues. One is a practical issue of treating so many lesions, but also there's, secondly, as you say, a biological issue, as it must to a certain extent reflect on the aggressiveness of the disease. Okay, thank you very much. Well, it is now, I've got one more question's just popped up. Thank you so much. Excellent presentations. Congratulations to the panelists and organisers. Hope to visit one day your centre. I didn't write that, but thanks everyone. It is now 6:59. We have to shut down, or we are shut down in 30 seconds or so. So thank you to all our panel. We have another seminar, the second in our series, on the 30th of November, chaired by Mary Murphy, consultant neurosurgeon, also Matt Radatz, senior neurosurgeon from Sheffield, the National Centre for Radiosurgery, where the seminar will be all about arteriovenous malformations. So you're all most welcome to attend that. So thank you, everybody, and good night from the panel.
Good night.
Good night.